We heard a lot this morning and this afternoon for calls to action for the Cancer Moonshot to be involved. You have our commitment and our partnership to make significant progress.
One of the clear aspirations of the Reignited Moonshot is to, as you know, reduce cancer mortality in the United States by half, by 50% over a period of 25 years.
Welcome to the Global Health Catalyst Summit. I am Vivian Kopsinger-Birchall, bringing you highlights from this summit. As one of the first agendas of this Global Health Summit was a response to the recently launched Oncology Commission in Sub-Saharan Africa that was preceded by a report. And part of the panel that discussed this response was Mr. Satish Gopal, who is the National Cancer Institute's Director for Global Health. Here are some highlights from that discussion and conversation.
Samira, and say 15 minutes feels like a luxury. I think given how crowded the agenda is with so many distinguished luminaries. But thanks to David and Will for including me. Thanks to all of the commissioners for producing such a clear and comprehensive report. I think in many ways this is already informing our thinking at the National Cancer Institute and will continue to do so. And I'm grateful to be here with, on behalf of the NCI, with some other colleagues from the NCI Center for Global Health, as Tim mentioned, having had my colleague from the NCI, James Alero, contribute to the Commission report, in particular the research sections. The NCI tends to be fairly well known all around the world, but I'm going to presume that everyone knows what the NCI is. So let me just, without going extensively into a description of the NCI and the Center for Global Health in my own work, let me just briefly introduce each of these entities. So the National Cancer Institute is the U.S. government agency that is tasked with really supporting all aspects of cancer research with the ultimate goal of improving people's lives. The Institute was established in 1937 and really re-established in its current form by the National Cancer Act of 1971, which was signed into law by Richard Nixon. We've been really fortunate to enjoy strong bipartisan support for Congress, I think, throughout our entire history. I sometimes joke that the importance of cancer research is one of a small number of things that Americans seem to be able to agree about these days, and we're really grateful for that. That's been, I think, a critical enabling factor in our success, both at the NCI and in relation to some of the progress that we've seen as a result against cancer in recent years. The Center for Global Health was established in 2011. And so it's one of the younger parts of the NCI. The NCI has always been engaged in global health activity, really from the time that the Institute was first established. But in 2011, it was felt that there was enough need and opportunity that this really required a dedicated center with a singular focus on global health. The Center for Global Health was established by Harold Varmus, who was the NCI director at the time. Some of you may have virtually attended last year's Global Health Catalyst Summit, which I think Dr. Varmus was actually recognized for having established the Center for Global Health, which I now have the privilege of directing. He now, you may know, chairs the WHO Science Council, which was established last year, and I think remains a really important source of wisdom and advice for me personally and for us as an institute and a center. And we've also enjoyed, I would say, incredibly strong support from NCI directors Ned Sharpless and Doug Lowy, who have been the other NCI directors during the period of time that Center for Global Health has been in existence. So that's CGH. Let me just briefly introduce myself. So I'm Satish Gopal. I came to the NCI 2 years ago after being recruited to direct the Center for Global Health. I'm trained as a medical oncologist. I think, as Will alluded to, I'm a little unusual that my entire academic life was spent living and working in sub-Saharan Africa before coming to the NCI. So I'm deeply familiar with many of the problems that have been articulated in the Commission report. Will mentioned, so just for the benefit of my Tanzanian colleagues, I'll just offer that my daughters are American, but have Kiswahili names, which is appropriate given today. And maybe just for Professor Ngoma, I'll say that my daughters would eat ugali or nsima 100 times before they would eat McDonald's. So we still make this in our house, even though it's not our native food, clearly. And these periods in my life are somewhat distinct from each other in the sense that I wasn't really looking for another job. I loved living and working in Sub-Saharan Africa, first in Tanzania and more recently in Malawi. And they're somewhat distinct periods, but they are very intimately connected with each other in my own mind and I think in some of our programming. So speaking with David and Will about today's event, they suggested that I try to offer some perspectives on the Commission report, again, from the perspective of the NCI. That's what I'm going to seek to do over just the next few minutes or so, without exhaustively describing all of our programs or our institutes or center, which I think is beyond the scope of the time that's allocated today. So these are the recommended actions that were put forward in the report. I've just taken this infographic from the report itself. And I think there are a number of areas in which the NCI, I should say, is big enough and diverse enough that we do some work that probably touches on each of these areas. But I think there are 4 areas in particular where I think we have a fairly substantial portfolio. And I just wanted to highlight some of that for you all today. So the first is precision cancer control planning. I think this has already been alluded to in our morning session. But since 2012, we at the NCI Center for Global Health, together with the Union for International Cancer Control and many other partners, have been primary supporters of the International Cancer Control Partnership. This is a multilateral organization involving a number of stakeholders all around the world. And really the purpose here is as countries, including many countries in Africa, decide that they want to develop, implement, and evaluate evidence-based national cancer control plans, this is an organization that really provides technical expertise to them as they're doing that. I don't want to trivialize the importance of subsequent high-grade implementation and evaluation and measurement, even following the development of an evidence-based national cancer control plan. But I think that what this has become is a really nice and rich community of countries that are at various stages of developing national cancer control plans. There's a lot of shared learning that I think goes on across this group, as well as I think we're generating a lot of evidence about what are the enabling factors and barriers that facilitate implementation of cancer control plans, even once they're developed with strong technical expertise and a sound evidence base. The second area I thought was useful to comment on, perhaps, is this idea around increasing cure and improving care. This is, of course, something that we take very seriously at the National Cancer Institute. One of the major vehicles by which we think that this occurs is making clinical trials available to patients, cancer patients all around the world. And I just want to highlight here the NCI's work in the AIDS Malignancy Consortium. So this is a NCI cooperative clinical trials group that was established in the early 1990s in the United States, because at that time, early in the HIV epidemic, patients with HIV were getting unusual cancers and were often excluded from cancer clinical trials that were typically reserved for HIV-negative patients. And so the NCI, responding to this challenge, felt that there was a need to develop a dedicated clinical trials group that could really understand these cancers in greater detail and develop best management strategies for them. Over the last decade, the AMC has recognized, I think quite importantly, that the vast majority of cancer burden for HIV-associated malignancies in particular occurs, not surprisingly, in sub-Saharan Africa. And there's been a real effort to recruit African clinical trial sites and investigators, including Ocean Road and some of the institutions in your countries, to participate in the AMC. And perhaps most importantly, develop clinical trial protocols that are well suited to answer the important questions that are occurring for this population in sub-Saharan Africa. At the bottom of this slide, I just showed a couple of recent papers illustrating that. A study led by Margaret Parrock, a senior investigator from Zimbabwe, focused on defining the best treatment for Kaposi sarcoma in sub-Saharan African settings, published in the Lancet a couple of years ago. This is one of the only examples of a large randomized phase 3 cancer clinical trial conducted in a multi-center fashion in sub-Saharan Africa. And then similarly, a study evaluating cisplatin plus radiotherapy for patients with HIV and cervical cancer, led by Dr. Ndlovu, who isn't here today. I don't think I've seen her, but is one of the commissioners from Zimbabwe on the commission report. And this is an area that we're thinking about fairly intensively, I would say now at the NCI, informed about how we as the NCI can uniquely contribute to building on these efforts to increase further the access that patients have to cutting-edge cancer clinical trials that are addressing important questions for cancer patients in an African context. And this is, of course, informed by numerous conversations that we participated in recent months with many external stakeholders. The third area where I thought there's a lot of synergy and alignment with many of the things that we're doing at the NCI is this idea of building and maintaining the workforce. The NCI is a research agency, and so we are principally focused on helping people develop cancer research careers. That's long been an important part of what we do domestically, and increasingly is a critically important part of what we do globally as we seek to diversify the scientific workforce. I think there's strong recognition now at the NCI that must occur if we are to facilitate the discoveries that are needed in years and decades to come. Just as one example of that, in the last year, we have initiated a new program, which is really, we understand at the NCI that there's already a substantial amount of really exciting research activity occurring, and I think that's been alluded to already this morning, at LMIC institutions, including many in Africa, often in collaboration with key international partners like US NCI designated cancer centers. In settings where that is already occurring, what we have sought to do is provide funding to establish dedicated cancer research training programs at an institutional level rather than an individual candidate level, so that these participating institutions can really create an ecosystem that supports the development over many years of a whole cohort and cadre of budding cancer research investigators really across all areas of science, basic, clinical, and population sciences, as we think that's going to be clearly necessary to ask and answer many of the important questions that the Commission report has raised. And then finally, David asked me to comment on this. I wanted to touch on this innovation and research idea. This, of course, being a research institute, is one of the areas that I think is best aligned with what we do on a daily basis at the NCI as our bread and butter. And David asked me to comment on this concept of moonshot versus ground shot, which I think is much discussed. Catherine, my colleague, Dr. Young, will speak briefly about some of their thinking currently at the White House in regards to the cancer moonshot. And of course, we're thrilled to be participating very actively in those discussions, largely providing expertise about what the research agenda should be. But just to simplify this, I tend to think of the moonshot as what are the discoveries that are needed to develop new and better tools and standards of care. And I think of ground shot as how do we achieve more even and equitable worldwide application of proven tools and standards of care. And I think we often have this debate about which is more important. And I think David sort of asked me to comment on this. Usually when I try to think about these academic debates, which I think we tend to become quite enamored of in academia, I try to think about them from the perspective of the patients that I took care of in African public sector hospitals over the decade that I lived and worked there. And I think for them, these are patients who are often, who I think have largely been forgotten by the cancer research enterprise, and are patients that we would typically describe as poor, rural, vulnerable, disenfranchised. We have a whole host of descriptors that we usually use for such populations. I generally found them to be incredibly smart, even if not formally educated, incredibly courageous and commitment in pursuing cancer care. I thought to myself many times in clinic, I'm not sure that I would have the fortitude to overcome these same obstacles to receive cancer treatment that these patients are clearly willing to overcome. And I think they make very reasonable decisions based on the options that are available to them and the information that's provided. And so I think if asked, do they prefer a moonshot or a ground shot, I think they would say we deserve to participate in both. And I tend to agree with them. And I think reflecting that, our Center for Global Health strategy that we developed, and this is publicly available on our website last year, more than just being a strategy for our center, I think this was really an institute-wide effort to refresh how can we augment what we've been doing in global health as an institute relative to what we've been doing over the last many decades. And so we've very intentionally chosen to prioritize a couple of really important areas of science among many broad research themes. So one of these is accelerating global cancer implementation science. We're really excited that really over the last 2 years, we've developed a really substantially expanded and coordinated program of implementation science funding opportunities to really support a community that can apply these new methods about how to test and validate strategies for delivering evidence-based interventions in a variety of complex health settings. We think that knowledge will really be informative to apply in other settings, as well as perhaps to other proven cancer control interventions, and we're thrilled that that's moving forward. Similarly, for many years, we've supported a program called the Affordable Cancer Technologies Program, which is really designed to develop new technologies that are amenable to LMIC settings that really address the problems that patients face in these environments. This program has included testing and validation of the thermal ablation devices that were alluded to earlier to overcome the barrier of liquid nitrogen cryotherapy, which is an unworkable solution for the treatment of precancer in many rural African clinics. This program has supported the testing and validation of urine biomarkers for colorectal cancer screening in Nigeria in settings where people call blood testing and colonoscopy is also not a workable solution. This has supported machine learning algorithms to automate many of the steps for radiotherapy planning to relieve the burden on scarce radiation oncologists in South Africa, and a whole variety of applications that we're really excited about. So I would say the patients that I took care of over a decade in Tanzania and Malawi really deserve both ground shot and limb shot. So I'll end there. You can find out a lot more about everything that we're doing at our website, email, Twitter handles, and look forward to engaging with many of you throughout the rest of the day.
Look out for more videos about the conversations that were held during this summit. Thank you for watching. Till next time.